Aloha, I am Mark Alexander, Executive Director of the Hawaii Medical Association. It is my pleasure to welcome all of you and thank you for joining us for this evening's Conversations at HMA, a program which features physicians and other healthcare leaders in Hawaii. This evening, we have a special edition for HMA members only with Dr. Mark Mugiishi, President and CEO of HMSA. Before I call on Dr. Angela Pratt to introduce our speaker, I want to review the format for this evening. We'll begin with opening remarks by Dr. Mugiishi for about 20 minutes. After that, HMA members have submitted questions for Dr. Mugiishi's consideration ahead of time. And once Dr. Mugiishi finishes his presentation, he will entertain those questions. For additional questions, comments, suggestions, ideas, we invite those watching the webinar to please go ahead and submit them through the Q&A function on Zoom. We also have people in the room, and we ask you to please go ahead and write your thoughts, your questions on index cards that are provided. Give them to Mark Conching so we can enter those in the Q&A function. We'll go through the prepared questions that members have submitted first, and should time permit, we'll address the other questions as well. Those here on site will have an opportunity to consider other questions and continue the conversation after the formal part of the program. The program will end promptly at 6:30 p.m. We want to hear from you, so please email us at info@hawaiimedicalassociation.org or contact us via our website at hawaiimedicalassociation.org. It is now my pleasure to welcome HMA President Dr. Angela Pratt, who will introduce Dr. Mark Mugiishi. Dr. Pratt.
Thank you. Hello, everyone. Good evening, and thank you for joining us. It's my sincere pleasure to introduce our distinguished member of our panel tonight, Dr. Mark Mugiishi, who all of you know came into the seat of President and CEO of HMSA in February 2020 during the pandemic. So I'd like to have him come forward, and so thank you very much for joining us. Dr. Mugiishi, as you know, has been practicing in Hawaii for over 30 years in the surgery department. I was fortunate enough to be his student, and in the surgery department, he taught me well. And I also remember times in the OR where I was really scared, but I remember you being coach of my cousin, Wes Pratt, at Iolani School, and he was an exceptional coach for Iolani School as well as an exceptional coach in the OR, teaching me and teaching all of my colleagues. He also has many years, like we all know, 30 years of private practice, as well as with JATSA and working in medical school, and then opened a couple of private centers, right? Endoscopy Center of Hawaii and the Eye Surgery Center. So a lot of experience he brings to the table. I'm so happy to have him joining us here tonight, and I am looking forward to us having a conversation here at HMA. But on a personal note, I just thank you for all the years of training me and keeping me in check when I called on you, even after I graduated.
Thank you so much.
Welcome, Dr. Mugiishi.
I just want to comment and start by saying that if anybody questioned the resilience of Angela Pratt, I mean, she was my student and she still went into medicine. It's still be amazing. But first of all, thank you to everyone here in the room and everybody on the webinar, to the Hawaii Medical Association for inviting me to have this conversation. It's great because I came from the provider community, and so to have the opportunity to have a dialogue with people who are every day out there delivering healthcare to our community. It's just wonderful because together it's our kuleana to get this right. So that's why I'm so thrilled to be here. First, I want to just celebrate together a little bit. This is HMSA's 85th anniversary. So it's a big year for us. We're very proud of what we've accomplished in 85 years, serving the community, being a community asset. Were we perfect during the 85 years? No, of course not. We weren't. But I do think we've been successful. We started as a little company founded by social workers with 600 people, and we're now 780,000 people who live in Hawaii rely on us to give them safety and security, and to be an advocate for their health and well-being as they live their lives here in Hawaii. So I think that's successful. And but a wise person once told me the hardest thing to do is to change while you're successful. It's really hard to do, but it's really a mistake if you don't. And so we acknowledge that it's going to be our responsibility to change with how times are changing so that we can get to a point where we continue to take care of the people of Hawaii as we need to take care of it. But the only way we're going to do that is in partnership with all our stakeholders and very importantly with the providers who really are our arms out into the community who deliver the care that needs to be delivered. And just want to make a little doctor joke about why it's important to change is you just have to ask the people who sold beepers to doctors whether or not you should change with the times or not, because they're gone, right? So, I mean, it's very important. And I just wanted to start in this part by talking a little bit about the macro forces or the mega trends, whatever you want to call them, that are surrounding healthcare right now, that kind of necessitate us look at how we all work and do business and how we have to change together. So the first one is this thing called consumerism. Really what it is, it's the way people now live their lives. It's like, I mean, you walk around every day and you see it's all on their phones, right? Everything is automated, it's immediate, it's digital. People are just much more comfortable with getting everything that they do in their lives right here and now in a very convenient way. The medical industry has been a little slow to be on that. We're still a little stodgy and we still require people to come to us. But it can't be that way forever. People are going to find other choices and other ways to do things if we don't respond to their needs. So that's one big thing. And all of that, doing that well requires automation, it requires technology. So it requires scale, it requires investments that require people to leverage all of their resources together to get there. So that creates the second macro trend, which is that there's a lot of consolidation going on. People are looking for ways that they can accomplish that. So whether it's hospitals like merging together to form bigger entities, or whether it's vertical where people are taking the insurance, the finance role, and the delivery role and merging it vertically into one company, or whether it's complete newbies coming into the industry, Amazon, CVS, Walmart, delivering care because it makes sense for them to try and do that. The world is changing in that way as well. And that's a big macro trend that is also happening. Then there's affordability. Affordability in healthcare is a national problem. We spend too much money on healthcare. 20% of the GDP is growing every year, whether it's because of pharma, whether it's because of the way we deliver care. It's expensive. And here in Hawaii, it's a particular problem because we are really unaffordable in general in Hawaii. And before we started this, I was just talking with one of our HMA employees here who was saying, yeah, my grandkids, they're going to graduate and stay on the mainland. I'm kind of sad about that, but they can't afford to come back and the opportunities aren't here. And we can't make that worse in healthcare, right? So we're actually like not bad. If you compare us to the rest of the country, US News and World Report ranked Hawaii #1 state in the nation in healthcare when measuring metrics for affordability, access, quality, and public health. That's a great honor. But they also, in that same ranking, they ranked us 48th in economic well-being. So our success in healthcare, we need to perpetuate that. We need to keep improving that. We can't contribute to the affordability problems here. So affordability is a big deal. And finally, the last kind of mega trend that I wanted to bring up that I think all of us feel shifts in the workforce. And that's happening at many different levels. Like HMSA is a big company. We have 1,400 employees. We see it. It's harder to employ people. It's harder to find people with specific skill sets. People want to shift jobs a little quicker. So, you have that shift in the workforce, and then you have shifts in the healthcare delivery workforce. Doctors, nurses, mental health providers, they're struggling to find satisfaction. And so they're retiring early, or even worse, they're silently retiring, right? They continue to work, but they're not as engaged. Productivity is down. And that is also something that we have to find solutions for. So we look at all of those, and typically when you hear all of those things like consumerism, consolidation, affordability, shifts in the workforce, the first place everybody goes is, oh, well, we have to change the way we do things, and we have to change the model of care, because you're not going to manufacture more doctors. They're short everywhere in the world. They're not suddenly going to appear. So you need AI, you need automation, you need all these different things, ways that you deliver care. The problem with that is when people are sick, that's not what they want, right? They want human touch. They want the relationship. They want somebody that they can trust with. So if we're going to take these tools that are coming up that are wonderful, they're going to help us. But if we're going to make them actually work, we have to create the way that they fit into the model of care in a way that integrates with the doctors and the providers out there, because otherwise it doesn't work. So what we're trying to do at HMSA is pivot from being a pure health insurer, which we've done for 85 years and we're still doing, to make sure that people get the security of being covered when they're sick, to being more of a health organization. And in a nutshell, all that means is we want to partner with all the different stakeholders that contribute to the health of the community, figure out how we're going to take these macro forces and adapt to them in our own unique way here in Hawaii. And to me, the first place we have to start is with providers, because doctors deliver the care. They're the human touch. They're where people are looking for reassurance and help and connection when they get ill, and also when they want to stay well. So we have to work with them to do that. So I can't cover the gamut of ways that we're trying to do that, but I thought I'd highlight a few. So first of all, administrative burden. Administrative burden is clearly a problem for physicians today, because it takes away their ability to spend time with patients. So how do you figure out? Oh, well, I'm just going to back up a second and say, unfortunately, like one of the biggest things that people complain about with administrative burden is all the things that they have to do for reporting, for pre-authorization, for all of those types of things. The sad news about that is that it probably is not going to go away for a couple of reasons. One is the mega trend of affordability. So people are looking at cutting waste out of the system. And the second is that the demographic of the population is such that it's aging. The population is aging. The population in Hawaii, at least, is migrating, the working population. So at HMSA, we predict that in about 5 years, the majority of our members and the majority of our revenue will be coming from government lines of business, Medicare, Medicaid, Med 87. And the requirements for reporting and pre-authorization and all those types of things are coming from the government. So we're not going to have control of making that go away. What we can do is have control over making it easier. Part of that is automation. So what we're trying to do is invest in our own technology structures to make things more real-time and easier. We used to have everything that we had in terms of information at HMSA sitting on an IBM mainframe as recently as 4 years ago. So that's a little mind-boggling, but true. So one of the first things I did is that doesn't work, because the information is disparate, data doesn't work. So we forced ourselves to get off a mainframe into the cloud, create a new data platform where things can move faster and be quicker, and then there can be real-time integration of information. So we're on that journey. We're there now. We're off the mainframe, starting to move in the cloud. We're starting to collect the data. We're We're putting it on a new platform. And that's going to be a way where the data can be more readily accessible and more real time and make things easier and make outcomes better. But there's still work for doctors because they still have to get things there. They still have to do forms. So we actually, and Nadine's here, Nadine Tensal, which is great because she and Kelly Wiki and our chief medical officer, Dr. Stephanie Park, are all working together at a physician administrative reduction initiative to figure out ways that life can, there's some necessary evils, but how do you make them less evil? Easier, more, tangible improvements in a doctor's life so that they can focus on the things that are important. Some of the things they've done already, I know, is a universal pre-auth form so that there's one form for all payers, right? So it's a lot easier than having to have a different form for all these different insurers. I think that will help. We're working on resources that will put all of the information that providers need, provider resource guide, in one place. Because right now you got to go 10 places. You got to look up this, you got to look up that, you got to go all over the place. We're working on that. I mean, apologies, it's not done yet, but I know Steph is working on it very, very hard with all of her team to get it there. We also are trying to leverage for administrative burden the fact that we at HMSA are part of the Blues family. So there are 33 other Blues plans, 34 of us, all of whom are trying to address the same problem. So whether you're in Hawaii or Arkansas or Massachusetts, or all of those places have doctors who are burdened with administrative tasks. So we all have to approach it. So we're leveraging solutions and scales. The one thing we're working on now is modernization of Blue Card. So those of you who ever take care of patients who are coming from a different state know how challenging it is to, you have to coordinate benefits for the plan on the mainland, figure out if they have different policies, then decide how to bill. It's just too much work. And so we're trying to do a new modernization of that whole system where it becomes just seamless. So that patient looks like they're your own patient, your own geography. For any of you who have ever worked on a technology project like that, I hope you have a little compassion for us that, and a little empathy that it's not going to be done in 3 months, right? It's like, this is a 5-year journey to get there, but we really are intending to get there. All the plans are throwing in money, investments to get this. And the framework, the chassis we're going to have after we do that is going to allow for stuff that we can do locally too, like real-time data exchange and, integrating clinical information with our claims information, providing real data analytics to providers. So I think that's a really good thing. The other thing, another thing that we're trying to work on is the shifts in the workforce, because we know that we're short in Hawaii in a lot of different places. Again, yes, we're doing things that are trying to increase the workforce. And that's multifaceted. Some of it has been with the government. Like we've worked with the current administration to get loan repayback for workforce, healthcare workforce people who are going to stay and commit to be in Hawaii. There's $30 million in the governor's budget to do that. We worked with the legislature this year to get a physician compact where we have reciprocal licensing so we can use workforce people. So somebody in Massachusetts on Eastern time who's 6 hours ahead, when they're done with their office, they can take care of people here who in the afternoon need some help and clinical care during the afternoon here. Those are ways we've worked with the government. With providers, we're trying to work on different models of care, how you can integrate digital health, telehealth into your practice that can help with your workforce, how team-based care can help you take care of more people. And we're trying to work with providers on ways to create payment mechanisms that will align with a new way of practicing, because the financing has to make sense in your own office, right? If we're telling you, you need digital care, you need a team of workers, how do we pay you in a way that allows you to make those investments. And we started that a few years ago with payment transformation. Was it perfect? No, of course not again. But we're working a lot now with physician groups to try and take feedback on how that is. Right now, payment transformation team, for example, is they're working on two fronts. One front is they're working with a pediatric work group to look at ways that the model can work for pediatricians because it's designed for adults. It didn't always work well for the way pediatricians' workflows work. Out of that, I think we had some great learnings, and we ended up carving out vaccine administration from the way they did things. And we have some other carve outs that I think have helped pediatricians a lot. And for the new versions of PT, as we're trying to roll out the new ways that we create alignment between the payer side and the provider side, we now have a physician organization work group where all the physician organizations are providing input to the different things that we might carve out of our capitated model to pay additionally to providers to incentivize the way that, not to incentivize, but to have it work to pay for the right way that they're working. And I think those types of conversations can only help us in the long run. So those are some of the ways that we're trying our best to work with the provider community. The other thing, a little bit talking about payment, is the world will be a better place, I believe. I might be wrong about this, but I don't think so. Is if more of medicine is paid for with value-based payments. And what that means is that instead of paying for quantity, like a number of visits, but you pay for outcomes. Payment transformation in primary care was our first effort to do that. Like I said, I like the concept. Our execution wasn't perfect. We're working now with primary care to get the execution better and better and better. But we've now actually started down that value-based path with the health systems. So we have value-based contracts now with all the big health systems. We have one with Hawaii Pacific Health. We have one with Queens. We're going to start one with Castle. These are payments that are tied to outcomes rather than hospitalizations. At the end of the day, what you hope for that happens out of that is that an empty hospital bed is more valuable than a filled one, because it means that all of us together are creating a healthier Hawaii. And the payments and the investments are being made all in alignment with that concept. And so, yeah, very excited that we've started down that journey. I think that's part of the reason why Hawaii is unique, because on a national basis, health systems don't get that concept. They really do not. And so it's been a struggle to get value-based payments into big hospital systems. In Hawaii, people are eager and enthusiastic to do it. So, and I think it's because we all have that same feeling of responsibility for the place that we live. That's one of the wonderful things of being here. It's one of the reasons why I feel personally so happy that I can have this job and be responsible for trying to marry all the stakeholders together. We're all actually aligned for the same common goal, which is to bring health to the place that we love. I just want to make sure I covered all the things I wanted to cover. So let me take a quick look here, and I wrote some notes. Because then we can go to questions. I did want to, I know I did want to say that probably a lot of you have read in the paper about HMSA outsourcing some of our functions, some of our back office functions. And I thought I'd share with you that we and I did feel that was essential along that path that I was talking about, is automation and improved technology was just necessary for us to do it. And in order to make real substantial progress in those areas, you need scale. As big as we are in Hawaii with our 780,000 members, we're tiny compared to the healthcare industry. and the kinds of technology investments you need to satisfactorily do back office, or to eventually have a consumer solution where everything can be done on an app, on a phone, or things like that that people are going to really be searching after. So we look to partner our back office, which is claims, membership enrollment, all the technology that supports those functions, to a third party that does this for a lot of other. Like, we have some wins and we can report early now. Credentialing, which I think was like one of the biggest gripes that we used to get. You guys take 9 months to like credential a doctor. What's wrong with you? It was true. Like, what was wrong with us? I don't know. But right now it takes 3 weeks. So that's a big win. Our provider call center, we went from, I wouldn't say hours, but it was a lot of minutes wait time, to now we're down to under 4 minutes of wait time, which is good. We're not perfect yet. We still have work to do on accuracy, on upskilling all of our areas, but I think it's going to be a positive change. And so, yeah. So with that, I do want to say I'm proud of our 85 years. I'm proud that we know we have to change. We know we have to morph to get to where we want to go. Again, I want to say U.S. News and World Report says Hawaii's #1, and that's because all of us work together and partner together. And we really have to keep doing that because it really is important that we stay there for the good of the people we all care for. And with that, Mark, I will be happy to take questions because I'm sure there are a lot.
Yeah. Thank you so much, Dr. Mugiishi, for setting the tone by discussing the mega trends with consumerism, consolidation, affordability, shifts in the workforce, and then talking a bit about some of the things that HMSA is doing already to address administrative burden, working with healthcare providers in very concrete ways, and the practical efforts that are being supported to support the changes and development in the workforce, as well as addressing some of the different payment models and the challenges that people have faced there. So thank you so much for setting that tone. And so I think, we'll get to some of these questions now that our members have put forward, and really appreciate your openness to doing that. The first one is, what is HMSA doing to address the doctor shortage in Hawaii?
Yeah, I think, we're taking a multifaceted approach, understanding that this is a big problem, not only here in Hawaii, but just nationally. Right? So if there was a surplus of doctors someplace, and we could attract them here, that's a much easier problem than there is no surplus of doctors. There's shortage everywhere, and it's hard to attract them here because we're in the middle of the Pacific Ocean and we're expensive. So that requires, I think, a lot of innovative thinking and partnerships. On the government level, like I mentioned in my remarks earlier, we're working on loan payback subsidies. We have physician recruitment dollars that we use. We're trying our best to get doctors interested in coming here by doing that. We hope that value-based payments provide an incentive for doctors who think that they can have good outcomes to come here and work in that kind of context. We're trying to increase access virtually, like I mentioned, by the physician compact. And some of the other things I alluded to earlier, I just want to talk a little bit deeper into here. We need to work together with the provider community to find out how certain things that are being used now to address the physician shortage nationally can work for our doctors here. Some of those things are telehealth, artificial intelligence, retail health. So we have, I'll just use an example, CVS is here. CVS has a big presence in Hawaii because they're now tied to Long's Drugs, which is a Hawaii institution. They can be a competitor to a physician in that the physician can believe that CVS Retail Health steals their patients from them, or they can be a supplement where you can take care of a greater number of patients because retail medicine is one aspect of your extended practice. So if we work with physicians here in Hawaii to see what would make them comfortable, how they could create workflows in their practice so that retail health can be part of what they do, we can increase the capacity that each physician can take care of more patients comfortably, safely, and well. But it's CVS can't dictate that, we can't dictate it. It has to come from a sense of working together to understand what's the model that makes that work. Same thing is going to be true with AI, right? Like there's no question AI is going to be part of medicine in the future. But what part of it, how is it going to be? Is it going to be a triage where it's going to help you decide when a patient calls in what comes to you and what goes to a nurse, what goes to here or whatever? Or is it actually going to render care? And it's, the technology is not ready to render care, but at some point it will be. And when it is, how does that integrate into your office? How does it integrate into your practice? And I think because at the end of the day, the patient is only going to accept it when the doctor gives them the guidance that this is a good thing for you, this is good for us, this is good for our relationship, then it can help create a new model of care that increases capacity. Again, that's something that has to be done in partnership with the physicians who are practicing and taking care of it.
As you mentioned during your opening remarks, the interface between technology and the human dimension is really important. So one of the other questions that came up from our physicians is, does HMSA still employ physician liaison representatives? They were very helpful in assisting physicians with issues and concerns.
So yes, we do. We actually have a division. It's called Provider Experience. And their goal is to make the provider experience better. Potentially, they felt invisible to the HMA docs over the last few years because during COVID, they were virtual. I mean, there were people there, but they couldn't go into people's office. So unless you actually knew that they were there, it might have been hard to reach out to them. They're back in person on the road, real time now. So if any of the HMA docs watching here or anything, you have issues, you should reach out and touch that office, the provider experience office, and there will be physician liaisons ready to help. Between the human beings that populate that office, again, like I said, we're investing in third-party technology solutions. We hope to have provider chat at some point, and not forever future, because that would be a lot better than having to have your staff having to wait, on hold on a call. So I think those types, there'll be a mixture of technology solutions as well as we'll always make sure we have human beings that can help shepherd provider questions.
Thank you. You touched on some of the work that you're doing with larger providers, but as you know, many rural and urban small practices are struggling keeping their doors open these days. Would you please share what HMSA is doing or planning to do to help these small practices succeed?
Yeah, no, that is a great question and is so actually crucial to Hawaii, because one of the unique things about us is that we're on all these different islands. And so every state has its rural communities and its urban communities, but the difference is that in other states, you can just drive from your rural community to your urban community. And that's not always true here in Hawaii. And so it really creates concrete access issues. So we rely on these small practices in the rural areas to take care of those communities. It's a hard problem because one solution for helping rural practices succeed is to give them more access to other types of care through digital care or things like that, but there's not broadband sometimes in these areas. So there's a challenge there. So they do have to deliver a lot of this care in person, and they have to do more things, right? Like, something that you could easily refer on Oahu to your friend down the street who can do that service. There isn't that friend in the rural area. You have to do it yourself. So our initial financing model and payment transformation, I think, missed that one. Honestly, we treated all docs kind of the same. That probably doesn't work, right? If you're trying to sustain a rural practice. So in our next version, we really are looking at ways to carve out things that have to be done by primary care in rural areas, carve them out. So you get paid for that separately than your PMPM. To give subsidies to rural areas. You know, if the population of your area is isolated in a certain way, we would subsidize that in a certain way. Small practices, rural practices. Those are all things that are on the table. We're calling it PT 3.0. That's going to roll out in about a year. Right now, the discussions about what exactly that looks like is happening between our team that's designing it and the physician organization leads. So if any of your members have input that they want to bring, they should talk to their PO lead and make sure that they are aware of issues that they may have so they can bring it to the discussion.
Thank you. You touched on reimbursement. Of course, as you know, a series of questions always emerge about that. So I'm going to ask you several of those. Some of us physicians hear that certain hospitals and practices receive higher reimbursement rates than some of those in private practice. Many of those in private practice, as primary care physicians, pediatricians, are struggling, which you acknowledge in your opening remarks. Is there any way for HMSA to be more transparent about the reimbursement system?
So going to the first question about whether or not providers tied to health systems get paid more than others, no, we have a statewide physician fee schedule that's statewide. It's the same for everyone. What can happen is, as I alluded to in my opening remarks, the health systems are involved in value-based contracts. So there's some opportunities for them to have upside. They have upside and downside risk because it's a value-based contract, but the quality and cost of care and care efficiency is higher. They receive shared savings payments, things like that, which they may share with their doctor. So, you know, it's possible that physicians who are working in those health systems are participating in that, but the actual payment for the base service is the same. The opportunity to participate in value-based payments can exist with independent providers, but it would have to exist through their physician organization or their physician organization teaming up with a management service organization, somebody who could aggregate enough doctors where it would make sense to take risk. Otherwise, you know, you put yourself in a bad position, actually, if you have a small practice and you're trying to take risk across your whole population. But we hope to get there. We have part of our strategy is because we know the independent practice is so important in Hawaii. Part of our corporate strategy is to have part of our clinical integration team just focus on the independent practice and what kind of capabilities do they need to be able to take risk and have a value-based contract. And you know, currently they're working on that. I think some POs are trying to aggregate. The POs are trying to aggregate with other POs, so they have more scale to do that. I think that's a great thing. We want to encourage that and keep encouraging physicians to try and leverage best practices and economies of scale to work together and get things done. So it is the same. We understand that it is hard when you're a small practice on your own. We are trying to work with the POs to figure out ways that we can be supportive. We do provide payments to POs to help with smaller practices. But we'll continue the dialogue to figure out how we can make it thrive. I think the best takeaway is that HMSA, I've been asked this before, we care about the independent practice. It is important for us in Hawaii to take care of the independent practice, and so we are focused on it.
Thank you. My primary care colleagues are wondering why the level of payments for HMSA board members is high when the primary care payments are low compared to their colleagues in other states.
Okay, so a couple of things. I just want to challenge the adjectives a little bit about high and low and what they mean. So we understand in Hawaii that the healthcare dollar is finite and we have to spread it out in as fair a way as we can. Given that, what we try and do in everything that we do is at least get to national media, because we know that the cost to live here is high. So if we're reimbursing anybody below national median and expenses are high, it's really hard to make a goal of it. So we at least try and get to that. For payment transformation, when we started this thing, we tied it initially to MGMA, the national median. So we wanted to get our primary care providers to that. So that was our initial cut. Since then, we went away from actually having a target number like that and saying we're going to get to that. But every year we invested an increasing amount of dollars, but we invested it on the quality side. So rather than it increasing the per member per month, increase the quality dollars. So they weren't distributed necessarily exactly an equitable way, like you got this percent, you got that percent. You had to perform to get it. I know that doesn't feel good to some people who aren't getting it, but we really believe that we're incentivizing the right thing. If you're producing a quality outcome, you should get more. And your incentive to strive for those goals, you should be rewarded for that with a financial payment. And so that's how we've approached that. So we in aggregate, we're at median or higher for primary care payments. Our board payment, our board compensation, and it's the same for executives at HMSA. We also try and hit national median, but we're below. So they would say we're low compared to national because we have not been able to get there. And we probably won't in the very near future because one of our commitments is to keep our administrative spend at industry lows. So on the mainland, you hear commonly this concept of the insurance company takes 85% of the dollar and pays it for healthcare costs, and they keep 15% for administrative costs. So HMSA has historically said, we're not doing that. We're doing 93.7. So 93 cents goes to the healthcare delivery system and 7 cents stays for administrative costs. Well, during COVID, we said, the need is out there. So we're gonna sacrifice, we're gonna outsource some of our efforts for economies of scale to get cheaper. We're gonna forego some of the ways we pay ourselves. And we got to 95.5. So now we're a nationally leading 95 cents out of every dollar goes to the healthcare delivery system. And we spend only 5% of our premium on administrative costs. That is the lowest in the country. And we're proud of that. And we're proud of it. So, yes, we're compensating our board. Yes, we think they earn it because they're fiduciaries of a huge responsibility and they are engaged in making decisions that influence the health of this whole state. And they take a lot of time out of their very important day jobs to participate in that. And we think they should get compensated for that. But we compensate them thoughtfully where it's below our peers, but at an amount that doesn't insult them.
So follow-up question with that,
Sure.
in terms of compensation of the physicians. So is the approach that you take to compensating primary care physicians, for example, is that what is the norm on the mainland as well?
I think it's very different because there are value-based payments for primary care physicians in other geographies that are similar to ours, but nowhere is it network-wide. So that's one of the unique things about Hawaii is that most primary care docs in Hawaii are accepting their payments this way. On the mainland, there are small pockets of them that are doing it, and they're also plan specific. So if 1/3 of my patients are from Blue Shield of Arizona, then I'm going to take payment in this way from them. United pays me in a different way. Cigna pays me in a different way. Here in Hawaii, part of the advantage I think that HMSA has with our ability to have a lot of the market because of our 780,000 members is that we can create a little bit more of a standardized way that we pay providers. I think it's a great solution, and philosophically, as I've said before, directionally the right way to go. I'm totally acknowledging the fact that it's still not perfect, and we have to keep tweaking it and improving it, and want to do that in collaboration.
With monthly premiums increasing by almost 20%, would HMSA consider increasing pediatrician per member per month PMPM with inflation? It's difficult when the supplies and immunizations increase with inflation, but our PMPM stays the same.
Yeah. Okay. So the first, just want to correct a little fact there, is that our premiums do not go up 20% every year. In fact, during COVID from 2020 to 2022, we stayed flat because the economy of Hawaii really couldn't withstand, a bigger economic hit by us raising premiums. So a lot of our peer plans on the mainland made a lot of money during those years because the utilization was down. And so they're increasing premiums, and the spend is less, the medical spend, the trend was down. And so they put a lot of money in the bank. We didn't do that. We didn't think that's not Hawaii, right? So we instead continue to pay providers with payment transformation, even though people no longer came to the office because they were stuck at home. Employers, rather than having them not be able to provide healthcare because their businesses were closed or not functioning, we gave them premium deferrals so they could keep people on furlough rather than terminated, and continue to pay their health care with us saying, but you can defer the payment until later, so people could continue to be insured. We did all those things and kept our premiums flat to service. So now we're coming out of COVID. So yes, the premiums will go up a little because there's a rebound in utilization. Right now, if anybody who is, all of you who are delivering care know that your office is full and they're overflowing, and the hospital ERs are overflowing, and inpatient beds are overflowing. So utilization is up, cost is up. So we will have to have premium increases, but it'll be nothing. So sorry for the long-winded thing, but I just wanted to level set that we're trying our best to fight this affordability issue as well. But as I mentioned, the way we're going to try and help pediatricians is with the guidance of the pediatric work group that's been advising our group. And one of the ways that they said we could help them most is being thoughtful about what things get carved out. And so certain things like vaccines, which was referred to in that question, that they're subject to inflation. So can you carve that out so we're getting paid to what we're being charged? And so yes, we're doing those things. We're trying to find different ways to make practices sustainable. And we'll continue to put more money in the quality bucket until providers like us through the feedback that you gotta bump up this side too. It's too hard or whatever. But we're listening. It's a conversation, I guess, is the best way I can.
And just so our members know what the process is, if they have input on these things, do they work with their physician liaisons, or how can they best communicate their needs in this regard?
So I think from a primary care standpoint, if you're a pediatrician, I would say the pediatric work group is really a good place to do it, because the issues for pediatricians really are different. Mm-hmm. So I think that's a really good forum to bring it up. And I think it's somewhere between monthly and quarterly, and it kind of depends on how many issues are up there, but it's an ongoing process. So they should do that. If you're in adult medicine and in primary care, I would say the best venue would be your physician organization, because that leadership is meeting consistently with our teams to redesign PT as it goes through evolutions. If you're a specialist, that's through the physician liaison office, and they can help you.
Thank you. You touched on administrative burden and prior authorizations specifically. Some of the physicians have observed that they're doing like 40 prior authorizations per week on average. What can they do or what can be done to help them avoid the retroactive denials?
Um, okay, so starting with the first thing about what can we be done about pre-auth. I mentioned in my comments, pre-auths are they're a hard problem because they're not going to go away. As I said, the couple of things that make them hard to go away is affordability is an issue, waste is an issue, and the fact that more and more business is government lines of business that have their defined pre-auths that HMSA has no jurisdiction over. We're just the administrator of government required pre-auths. So it's not going to go away. Now, that being said, if it's not done well, it reduces the quality of care because physicians are doing paperwork instead of taking care of people. So we are doing everything we can to streamline that. Like I said, Steph and her team are working with other docs in the community for single form. We're working on our technology. We're migrating platforms. In fact, right now in our department to uplift our, and again, it's not going to happen in 2 months, but to uplift our utilization areas so that intake, processing, decision are all on one platform, are quick, easy, easy to input, and ideally at some point transparent. Because think about the wonderful, how much better a pre-auth would be if when you submit the pre-auth, it's sitting on your phone, like that the pre-auth is pending, and it says where it is, it's taken in, it's with a medical director now. Here's a decision. Okay, why did it get denied? The reason is there. And then the next step, what should I do? Those are the things that with scale, with third parties that are helping us because they're trying to develop this. Everybody else is having the same problem. We hope we're going to get there sooner rather than later, but it's going to take a little bit of time. But those are the things we're trying to think about to make life easier for pre-authorization. And you know what? The member might see that too, or for you, the patient, which is really important because I think right now patients get frustrated, like they don't know where it is. And they're going, what happened to my MRI? And then they blame us at HMSA, they blame you as a provider, they blame your nurse. And a lot of people are getting blamed for something that technology can fix that actually, if we can figure out how to do it.
So related question to that is the use of the gold card, I think it's called. What are your thoughts on that?
No, we absolutely want to use a gold card because we think there are a couple of different ways that you can make pre-auth diminish to a large degree. One way is value-based care. Value-based care makes the requirement for pre-auth go away because the waste that we talked about, everybody's incentivized to watch out for that, including at the provider level. So you can cut down on that. And the second is proof of good behavior, right? So if you show like, hey, look, I always follow the guidelines, the clinical guidelines. Why would you question me on this one? That's another excellent way to make pre-auth go away. So, I know Steph works with that. They're getting creative. They're doing things like creating reports for doctors of specialty. Here's your performance. Here's your peers. Here's where you are. And we all know, hey, I'm a doctor, so I know this. We're all very competitive. So the second you see that somebody's doing a little bit better than you, you say, okay, here I go. I'm gonna fix that, or I'm gonna find out what I'm gonna do to get better. So I think yes, goal carding is a very effective tool and something we like to use.
The New York Times recently published an article entitled "The Moral Crisis of America's Doctors," addressing the moral injury many physicians are experiencing such that they are leaving the practice of medicine. Do you think this is also a problem here in Hawaii? And if so, what can be done to help address it?
So the first question is easy. Yes, it's a problem in Hawaii. The second question, what to do about it, is harder. First, I'll say, I don't know if everybody read that, but essentially the gist of the article is that a lot of physicians are burning out for many reasons, but in this particular one, it's a moral burnout because the idealistic reason that they went into medicine is becoming minimized over time. And the forces around them, when you talk about, like even the things I talked about, affordability and consumerism and consolidation, shifts in the workforce, those are all like massive, massive forces that are shaping what we do things, but it has nothing to do with patient care, right? When the doctor looks at that. And so it creates this sense of moral burnout. Like, why am I doing all this stuff? The stuff that this is what I signed up for, was to take care of that person. And now I have to worry about all these things, all of the things that surround it. It's burning people out. I think the biggest problem is it's burning out a lot of people in a lot of industries. It's not unique to medicine. It's our world has become complicated, hard, unpleasant in some ways. And when all of that happens, this kind of like erosion of your moral sense starts to happen. And it's not easy to fix because we still have to live in the social context that we live in. For what we can try and do in medicine is provide the relief for doctors so that they can go back and focus on the things that they thought they were signing up for. And that's what we're trying to do. But again, we're trying to do that in the context of all these other demands are happening, that any one of them can actually bring down the industry. So you want to protect the industry while taking care of the individual pieces, the well-being of individual pieces that make it actually work. So I read that article and found it very poignant. But the authors started off by saying, the reason why I shifted to medicine is I was having this conversation with all these other like industries, and they were all not as forthcoming about the reason. So I thought I would talk to doctors because they would be forthcoming at least. But it just goes to show the breadth that this problem is. It's kind of a national problem.
Thank you. We have a couple more questions we want to try to get to. The next one is, what physician and patient resources are available to help patients navigate the plan choices and coordinate care, such as drug benefits, dental, hearing, vision, and wellness benefits?
Yeah, and that's a great question because all of us who work in the healthcare industry know how fragmented the industry is. So like a lot of these things are not even tied together. And one of the frustrations we have is that almost maybe more than half of our members who have our medical plan don't have our drug plan. But they just assume that they do, right? And we can't coordinate the benefits because it's different. We don't have their drug data and all those. Anyway, that's a problem that needs to be solved. So it's more coordinated and easier. And that in the biggest, broadest sense is the requirement for data in the cloud, more automation, integration of information so that we can solve that problem. But that's a multi-year, multi-billion, very complicated solution that we can get to because Facebook and Amazon and all of them figured it out. We have to figure it out in healthcare. In the meantime, the things that we're trying to do at HMSA to help with that is we're building a resource at HMSA. I can't remember the name of it now, but it tries to provide guidance to physicians to help their patients shepherd through that. But that's extra work for the doc if they have to do it. So we're also at the same time trying to upgrade our website so that information is right there and it's easier to get to. So the patient can self-service himself a lot easier by going on the website, trying to find things. I don't know if anybody looked at our website 3 years ago compared to now. Dramatically better, still not perfect, still ways to go. And we're trying to leverage, we look at some other blue plans that have a lot more money than us, have bigger technology departments that have had really creative ways, and try to copy them. But it's going to be good for our members if there's more simplicity and easy navigation on our website. So those are the kinds of things we're doing to solve that problem.
And one last question, Dr. Mugiishi, as a former practicing surgeon, what is the most rewarding aspect about your role as president and CEO of HMSA?
So some days I'm not sure, but no. I'll start with what I miss most about practicing medicine. So, and specifically surgery for me. So of course, for all of medicine, right, the most rewarding thing is there's a person right in front of you and you're taking care of them. And at that moment in time, feel like the most important, most impactful person in their life. That's a privilege and an honor, and that's just the greatest thing about being a physician. So I miss that. As a surgeon, there are three things I always tell people I miss. So when I was in the operating room, you're in a room and everybody in the room is trying to help you. And there is nobody from the outside that's bothering you, right? And then there's a beginning and then there's an end. So those three things are wonderful. Made life as a surgeon just great. And all of those are gone for me now. I don't have any of this. I don't have any of it. But what I do have, which is the reason why I keep plugging along, is I have privilege and honor of trying to do something wonderful and magical and big, which is create a health system that will take care of the people of Hawaii sustainably and in perpetuity. And when you think about what that can mean for our generation, the next generation, the next generation, that's an honor and privilege that not very many people have a chance to get. So I feel very lucky to be able to lead a group of people, employees at HMSA who all have that same purpose to do that, to work with stakeholders. I view HMSA as 5 stakeholders, right? We have providers. Put them near the top because you're our, this is going to sound a very insurance-y thing to say, but you're our product. Like, what are we selling? We're selling these wonderful people who are taking care of you, right? That's what HMSA is. Then, of course, we have our members who are really why we all exist. It's why you exist as a provider. It's why we exist as a company. It's to take care of the people. Government is our stakeholder because they are our regulator. So you got to listen to them, and they're rapidly becoming our biggest customer. So they're a big stakeholder. Employers are our stakeholder, and they're important because they pay the bill, number one. Number two, people spend most of their day and most of their life in that setting, so they can influence health. And lastly, in Hawaii, with the Prepaid Healthcare Act, they're very special. They give us here in Hawaii something that no other state in the nation has, is that guarantee of care. You're guaranteed, you're covered, you know, and that is that's fantastic. And our last stakeholder is our communities, because you're not going to create population health if you don't have healthy communities. And so the work that we do for the social determinants of health and the pillars of social determinants of health, right? Economics, education, social context, built infrastructure, all of those things have to happen if we're going to create a healthy environment for people to live, work, and play. So the privilege I have to work with all of them, that's the best thing about being an HMSA.
Well, thank you very much, Dr. Mugiishi, for sharing, your time, your wisdom, and being so transparent and addressing our questions. Really appreciate it. And we're looking forward to having some little refreshment afterwards.
Sure.
So thank you so much. And to all of those tonight who have joined us for this edition of Conversations at HMA, we really thank you very much. And again, very big mahalo to Dr. Mugiishi for being with us, and to all of you for participating. We know you have the choice of your evening activities, and so we appreciate you spending some of your time with us here today. We thank all of our physicians who belong to HMA. We thank you for being a part of a community that is committed to physicians, to patients, and to community health. Mahalo and good evening.
Thank you so much, Mark.